Dear colleagues, it's my great pleasure and honor to be able to open this new session with you, which will be the ELCC 2022 Industry Satellite Symposium from Novartis, looking at the very broad and important topic, the management of patients with oncogene-driven non-small cell lung cancer. We have entitled this session, The Shift Towards Personalized Medicine. My name is Solange Peters. I'm the head of medical oncology at the University Hospital in Lausanne, and I will have the pleasure to drive you through this session, chairing this session with the participation of my colleagues I will present later on. This is a faculty, so I will have the honor to be here discussing this topic and on the various perspectives with Anne-Marie Baird. Anne-Marie Baird has a key role in Europe because she's the president of the Lung Cancer Europe. It is the patient advocacy group for lung cancer in Europe, called also LUCE, from Dublin in Ireland. Professor Reinhard Büttner, who is professor of pathology at the University of Cologne, University Hospital in Cologne in Germany, is one of the leaders of lung pathologists in Europe. And Noemi Reguart, who is a friend and colleague working at the Hospital Clinic de Barcelona, Institut d'Investigacions the Auguste P. I. Senior. I'm not sure if I tell it right, but in Barcelona. And she's also a key opinion leader participating in all guidelines in lung cancer, trying to define the best standards of care. And this is the agenda. We'll try to comprehensively cover this important topic. After this welcome, we will start a discussion and debate with my colleague Anne-Marie Baird about the comprehensive biomarker testing, trying to understand the person's perspective and sitting probably in another chair as usual to try to understand how patients can perceive this complex step. The second discussion, second talk will be given by the pathologist, Professor Büttner, known your options biomarker testing at the foundation for treatment selection, which will be followed by data and more knowledge about targeted therapy given by Noemi Reguart in a talk entitled Emerging Landscape in Biomarkers. We will follow that by a panel discussion about trying to integrate all of these concepts, integration, how can we bring the future forward? And one important point, if not the most important, we'll have 10 to 15 minutes for Q&A at the end. And you will see later on, it's very easy. We need you to participate because the most important thing is that at the end of this session, everything will be clear to all of us. We will try to follow these meeting objectives, explain the importance of performing upfront comprehensive genomic profiling to determine the most appropriate treatment for each patient with non-small cell lung cancer, defining correctly their journey through the disease, trying to understand the importance of and the challenges associated with discussing biomarker from the person's perspective, and discuss opportunities for best practice and incorporation of new technologies to provide personalized treatments. So a very full agenda, and I'm very happy to have you with us today. And this is just as a demonstration of how to do to be more with us with interactions with the chat and the Q&A sessions. And we encourage you to actively participate by submitting all the time longer these questions through the Q&A that we will answer at the very end of this session. And with it, I wish you a very interesting moment all together, hoping to be able to interact in some minutes with your questions. Thanks for your attention. About an important perspective, which is the one from the person who might be affected by cancer. It's probably the most important, by the way, to understand how our scientific data can be conveyed to the persons who should know about it, right? And to do that, we will discuss it with my colleague Anne-Marie Baird, who is the president since a bit more than 3 years of the LUCE, the Lung Cancer Europe, the Lung Cancer Advocacy Group, patient advocates, I would say a coalition, and she's from Dublin in Ireland. Very importantly, there are few lung cancer patients group, right? Because it's a tough disease and there are few people who are ready and have time and energy to commit in such initiatives. And it's particularly important in the field of lung cancer, where biomarkers are so complex, to have you on board, right? To let us know from maybe the unique group which can help in Europe to understand how it is perceived. So maybe I will start with one question, which is very naive, but then we can go into the granularity. But what do you think, Anne-Marie, about the perception of biomarkers among the patients and relatives you might meet? What does it mean, a biomarker, for somebody who receives this diagnosis of probably advanced metastatic lung cancer? Is it something which is obviously requested by all of the patients, or it is something that they don't really know about?
Well, that's a great question to kick off with, and huge thanks for having an advocate patient voice as part of a satellite symposium, because it's not often that you get the opportunity to sort of chat from that perspective. So I think from our experience in Luce, it is very varied. You have people who are very up to date with everything. You know, they go to their clinicians, they can have a very in-depth discussion around biomarker testing, what's appropriate for them, what way it's going to be carried out, what's the next steps, are the treatments available, or should there be clinical trials? But in general, there is a lot of confusion around biomarker testing. A lot of our community feel that if you get biomarker testing, it's the same no matter where you get it. And we know that's not the case. For a lot of people, they have absolutely no access to biomarker testing. They may only have access to, you know, a small cohort of sort of maybe the more common mutations. And then for a lot of others, they may have an opportunity to get broad panel testing. So there is a lot of kind of misunderstanding and confusion, but I think we have to be very aware that, you know, all of these advancements, you know, I'm sure that will be talked about in this session, is something that's not a reality for everyone across Europe with lung cancer diagnosis. This can vary within country and across country. So I think we need a lot of consistency, and then we need to improve the communication from the clinical side of things to the person that's sitting in the clinic, so they can go away knowing exactly what type of cancer they have that accurate diagnosis. And then if they need to, you know, access any supports, they're able to do that because they know exactly what their tumor is. Unfortunately, that's not happening, because in recent work we've done, about 30% of all of those who responded to a survey didn't know if their tumor had been tested at all. So there's a lot of work to be done within this space.
Yeah, I was very surprised. And by the way, these data are available online. If you go to the Luce website, you can see all of the surveys and data you have been producing from the patient perspective. But I've been very surprised, I would say disappointed, to see the most recent data you produced about accessibility to NGS biomarker testing in Europe. While sometimes in my country, Switzerland, it looks obvious that NGS is almost everywhere. It's really accessible today to a minority of patients in Europe for NGS, and maybe simple biomarker or molecular assessment for also a vast number of patients in Europe. And we are conducting such a survey also in collaboration with the European Society for Medical Oncology and Gustave Roussy to try to see how it evolves in Europe, but also maybe broadly in the world, right, globally. Yeah. But I'm sure that the picture will not be improving so much. My feeling is that we are stuck with these inequalities in how the journey of a patient will be different from one country to the other one. Do you have the feeling that, first of all, there are ways we can make it improved, or we can manage a better assessment, or politically do that? And do you feel like it improves? Because after COVID, I'm not so sure it has improved. What do you think?
I think, you know, if we look sort of within the last decade or so, yes, there have been improvements, but I think it's really, really important that we understand that, like anything, if you are looking for a specific answer or a specific response to show that you're doing better than someone else or you're doing worse than someone else, you know, you can be that selective when you go looking for that data. So you have to be careful that when you go out and look for information, you're looking at a broad spectrum across a country, because sometimes what we experience is, and you mentioned that report that we did about access, is what we were hearing from companies and from clinicians was very different from what we were hearing from our responses from our caregivers and our advocates. So there's a huge disconnect. And even at that, you know, the responses we got from companies, clinicians, and those with lung cancer, there was no consistency. So if I've just been diagnosed with lung cancer in a particular country and I'm trying to find out what I should have or what's available to me, I'm not able to find the proper information. So then it leads to a huge amount of confusion and stress when already a lung cancer diagnosis in and of itself is so stressful. And I think there's a need to recognize that, you know, at the end of the day, if someone comes and they have an EGFR positive lung cancer, it's still a lung cancer. This person was not expecting to get lung cancer. And there can be this drill down into EGFR, for example, with people then forgetting the impact of a lung cancer diagnosis. So it's important to remember that there are differences, that it does take time. And it just can be such a stressful time. And this is why we need that very clear communication. In terms of improving, I think everybody has a role to play, but we have to come together with consistent messaging and a consistent goal in mind. And to do that, we need to get everybody on board to help increase the patient advocate voice. Because I think if you look at other cancer communities, such as breast or prostate, you have a very strong voice, a very forceful voice that is driving policy change, that is driving awareness change. And I don't think we're quite just there yet in lung cancer. It is improving, but we need to do more. And I think if we have that cohesive, strong voice, it will then hopefully impact policy changes and reduce those inequalities that are faced within and across countries in Europe, because we know that having an accurate diagnosis of lung cancer is the best option you can have then to get the right treatment for your type of disease.
I'm very happy to hear you speak about the discrepancy between our testimony of biomarker testing and the one from patients, because of course, you know, the most vocal people at meetings and various kind of educational events are usually the ones working in institutions where biomarker testing looks like to be an obvious, I would say, solution and not a challenge anymore. But of course, health systems are very complex. So in many countries, there is a bunch of private practices or smaller practices where it's not so sure that the full access to biomarker testing is granted across all disease types, because they are not lung cancer specialists, they are cancer specialists. So what I mean is the only way to survey the quality of care in complex health systems like ours in Europe is potentially to go to the patients and ask them, what did you get access to? Or what type of discussions could you have with your doctor? And how much did he go into the details of characterizing your tumor? Because it might be sometimes that this breast cancer specialist doing some lung cancer might have forgotten about some of the biomarkers which are important. So I guess it's terrible because it puts a lot of weight on your shoulders of patients. But getting the information through your community telling that at least you need to be tested at this point for advanced disease for these biomarkers is standard and evidence-based kind of patient guidelines is probably very important.
It is definitely very important. But I think we need to also appreciate that where we all have a role to play in, you know, educating people with this disease, I think we shouldn't put ourselves in a position where that's our only single focus and that's where we're putting all the pressure on, because that person's dealing with so many things. I think the clinical community also have to step up and do more, and it has to be a two-way street. You know, whereas, you know, clinicians are keeping more up to date, they are improving how they communicate with individuals so that when someone walks out of a clinic, they know exactly what type of lung cancer they have, what stage of disease they have, and so on. Because I think we are moving to a point where people are incorporating the patient voice more, which is excellent. I'm not saying that's any way negative, we need more of it. But I just worry then we're going to the other side where all of the pressure is going to be put on people with this disease to know everything about everything. And I mean, thankfully, the lung cancer treatment landscape is changing. But in changing, it's becoming so complex, and a lot of, you know, specialists within the area are struggling to keep up. So, I mean, if you can admit you're struggling to keep up, how are advocates going to keep up to know exactly what they should have at this point in time?
I agree. I guess it's really about making sure that we have guidance and guidelines for the doctors, also for the patients, hoping that they will complete each other. It might be also in the hands of national or international organizations to make this kind of promotion. They all encompass some patient advocates, and they must probably make the political move. Well, politicians, being physicians, are missing in every country. So we really need to try to be a bit more present in this equality field, right? Because having access to the right diagnosis is about making the right journey through the disease. I'm sometimes surprised, and that may be something that you need to guide me through, but about the level of information. I wonder sometimes it's a question of generation, because we are probably a web-based generation, a digital generation. So we use Twitter to get info and so on. But even through all levels of information, you have, first of all, lots of questions and anxiety. Speaking about genomic profiling, very often the question is, first of all, confusion. You probably have patients coming with the name of a drug, sotorasib for KRAS, asking if he can take this drug while he has no mutation or even a squamous disease, just because advertisement is betraying everyone, lots of advertisements and so on. So not understanding what a mutation is. And the other very big anxiety is, what about my family? You tell me my genes are broken. What about my... So lots of little things that we should have been able to convey through digital for the new generation, maybe through which format for maybe the 60, 70 years old population of patients. What should we do to make sure that the basic messages are well conducted, well given to the patients?
So you're probably not going to maybe like my response to this, but it's really, while we would all love to have that magic bullet, that one way to do effective communication around biomarker testing within this disease, it's not really possible, because you are dealing with different generations. You're dealing with people who access information in different ways. You still have a lot of people who only want to hear things from the clinician and nowhere else. You have others that want to have something in a hard copy, something that's paper that they can take away and read and, you know, think about questions at a later stage. Then you have, I guess, the internet search experts who are going on every single site they can find to find out information. And I should caveat that by saying, from information we've received back from our community, a lot of that information can be hard to find, is often incorrect, not up to date, and is not properly created, which is then influencing things when they're trying to understand their disease and make a decision. So you need to be able to co-create these information materials with the patient advocate community to ensure they're fit for purpose, because sometimes we run into a risk of, I have a list of things I need to do, I need to produce this, tick, I've produced it. Is it fit for purpose? Is it being used? You know, can we treat it as a dynamic living document so that we can evolve it if we get feedback saying it's not actually fit for purpose? These are things we need to think about. And I think what's often forgot within a European community is we need adaptable materials. And what I mean by that is you need materials that are easily to translate into other European languages. You know, you need to have materials that are easily adaptable in terms of there's cultural differences, healthcare system differences, because when that's not the case, people who have limited capacity and resources are then going back and sort of redoing something that has already been done because the materials may not be adaptable for their community. So we kind of have to think more broad term and just not make assumptions that we only need to produce information in one way, because if we have that mentality, we're actually going to increase inequalities rather than tackle and improve inequalities. So I think that's just something that's really important to remember, particularly when it comes to languages in a European perspective. And I might just go back to the political side of thing, if I may, and apologies now if I'm circling. It can be difficult to get, I guess, political interest in lung cancer because of the link with smoking, and a lot of people then don't want to be seen to be involved because there can be a feeling that, oh, if I go out to support something in lung cancer, people may feel that I'm pro-smoking. There's a lot of very strange assumptions that people can make. But on the other side, people can come with a lot of biases as well, which influences whether or not they're going to support something. And for us as an organization, what we're trying to do, and this sounds the most basic thing ever, but this just shows you where we're at in some places, is humanizing the disease, saying this is lung cancer, this is what it looks like, this is what a person's experience is of this disease, and this is why we need to do better. In terms of your other question around worrying in terms of passing something on to a family member, we don't tend to get a lot of those types of questions from our community because they do tend to understand that it's, you know, talking about their tumor. But again, it is something that's important to clarify in the clinical setting to say, look, you know, this mutation that we found, it's only within your tumor. It's not something that you can pass on to your children and so on. So if that is a nagging query in the back of someone's mind that they may be too scared to ask, at least by putting it out there, then it can take at least that one worry away from them.
Yeah, thank you. It looks like a very, I would say, difficult mission to fulfill, to make sure that the information we convey is adequate, understandable, and up to date. I have been seeing, you know, the efforts of our national society in my country and the ESMO. We prepare, but it's still not comprehensive, these guidelines adapted to patients. But it might be they are too complex. They are certainly not reactive enough to adapt to new data, so that they are obsolete quite fast. So suddenly the scenario of your disease is not there, which is not acceptable. Yeah. And the last thing you told, which is probably right, is we now have created in many institutions what we call patients' lab, meaning places where this kind of documents go through the scrutiny of people who know what it means, what the words can have as impact and how they can be perceived and maybe improved. So I think there might be, and for this, we need to ask the pharma industry to help us. We might need to build the whole machinery at the European level, US level, African, and so on and so forth, to build adapted guidelines for patients who can be updated as often as the NCCN guidelines. But we need money, people, patients to help to do that. And I guess as long as we won't have done that, we will have an imbalanced kind of level of information. If you do that, then you can translate that, have money for translation, print them from the web if the patient has no web connection. Everything can really be, I would say, smooth logistics through a web platform, but it needs people and money, and I think we need to do that better. The last thing you told me was very nice is about stigmats, right? In lung cancer, the problem is the stigmats, and we always try, and we are guilty about that, but to tell the patient, the community, and society that nobody is guilty from having cancer. The guiltiness is on the disease. There's always a component in every cancer of bad luck. And then we all have attitudes with a certain level of risk. But anyway, cancer is part of bad luck. Not that people should smoke, not that people should be obese, but I would say not that people should be sedentary. But I mean, you can never blame anyone for having got this bad luck following any kind of behavior, right? So that's really something we should work on. So you have the last word. I spoke too much.
Well, I think it's fitting we finish on the stigma part, because we know that stigma influences everything. I mean, this session, you know, we're talking about comprehensive biomarker testing, personalized medicine. And because those are words that are used so commonly, we automatically make an assumption that everybody then has access to these because they become common terms. They're in the language. But stigma is impacting how people can get information, how they can access testing, how the policies are made, where the money in healthcare is put. So stigma has an impact there. And it is an impact of when people go to try and seek help if they've got symptoms. The stigma and the fear of being blamed for their disease can prevent them from going to their primary healthcare professional. We've had a number of people in our community talk about, you know, how they felt when their doctor spoke to them, and they just came out feeling it's all my fault. I'm such an awful person. But at the end of the day, we need to understand that anyone with lung cancer does not deserve the disease, irrespective of their smoking history. And we also need to put our hands up and recognize that smoking is an addiction. It's a highly addictive, nicotine is a highly addictive substance. And when you look at people who are addicted to other things, like other types of drugs, alcohol, whatever it might be, we need to apply the same empathy and support and all of those things we give to anyone else with a disease or a condition as we do for those that are living with lung cancer. And what I'll also finally say in terms of stigma, people say, oh, you know, we don't use stigmatizing language, we don't use stigmatizing images. But if you were to sense check yourself, you will find that people still do that. They still have the images of the cigarettes. They still talk about how lucky you are, you've early stage lung cancer, how lucky you are that you have an oncogene driver identified in your tumor. Let's remember, nobody is lucky to get lung cancer. And what we need to be talking about is access to comprehensive biomarker testing, and in parallel, the treatments needed for those oncogene driver mutations for everybody impacted by the disease.
Thanks a lot. Very moving last words. Thanks a lot for your words. They are very important to us. They're probably more informative than anything we could do. So let's move to the scientific discussion, the ones that we hope we can make understandable to all of us, which will be given by our pathologist, Reinhard Büttner, who will speak about how fundamental it might be to have all the knowledge and the technology in hands for biomarker testing in order to prescribe the right drug to the right patient. So welcome, Reinhard, and we're looking forward to listen to you. And thanks again a lot, Anne-Marie.
Thank you.
Good evening and welcome to this symposium. In the next presentation, I will show you how comprehensive biomarker testing lays the foundation for clinical treatment selection. And here are my disclosures and a view over my city, Cologne. And it's clear that with the advent of the discovery of oncogenic driver mutations, we had biomarker in hand that would allow us to select and deliver targeted therapies. And that really changed the way how lung cancer was treated over the non-selective chemotherapies we had in the old times, 20 years ago. And nowadays, broad molecular testing allows for better informed treatment decision making. And here's a view on the panel and the genes that are regularly being tested in a default pathway in a reflex mode from first-line therapy onwards. So every non-small cell lung cancer patient with advanced diseases receives this molecular testing, and you see the high frequency of mutations, tumor suppressor mutations, but also oncogenic driver mutations that allow to select targeted therapies are found, and practically we found one or several mutations in every lung cancer patient with the 12% EGFR mutations, with the high frequency of KRAS mutations, and many others. And that has dramatically changed the outcome of lung cancer patients. There is a trend towards lower incidence in the United States and the Western world, mostly due to a decrease in cigarette smoking. However, also the incidence-based mortality rate is decreasing both in male and female, and that is the result of a more effective and selective therapy that is delivered today for these patients. And an overview of the treatment selection is shown in this cartoon. There's the first-line therapies with EGFR mutations, the many fusions we find from ALK to NTRK and RET. The new ones are MET mutations and RET fusions. Then most of these tumors go into resistance and relapse and need re-evaluation and delivery of further TKIs that overcome the resistance mechanisms. On the other hand, we have a large portion of tumors that receive immune therapies or chemoimmune therapies, and depending on the PD-L1 status. And now with the advent of new immune therapies like LAG3, TIMP3 targeted immune checkpoint inhibitors, there will be also a plethora of tests that need to be performed to select the best mode of immune or immune chemo combined therapies. And that calls for comprehensive genomic profiling, which simultaneously detects rearrangements, copy number alterations, base substitutions, and small insertions and deletions, so-called indels, in a comprehensive way, because we need to have all this information in front of the first-line therapies to plan the therapies of the patients, and therefore we need a comprehensive analysis of DNA and RNA-based NGS sequencing. And there's clear evidence, that's also from the German network, from the international groups, but also in these publications, that patients that receive comprehensive genomic profiling in an early phase of their disease benefit massively from these diagnostics over those patients that are not being tested and receive non-selective, less effective treatments. So the question is really, what is the pathological decisions? How do we diagnose? And it's really the pathologist that has the material in hand. Larger resection specimens, mostly in lung cancer, smaller biopsies, even cytological specimens or blood with circulating tumor DNA. And all of these materials are super precious to deliver a comprehensive diagnostics. And therefore, a pathologist must have in mind the entire diagnostics and clinical decisions and treatment pathway of the patient before he starts even with his diagnosis. So there are in principle two ways to test for mutations. One is a tissue-based, and I don't want to get that information missed. We strongly believe that every lung cancer patient initially must have an histological diagnosis based on tissue or cytology, because we need to know, it's an adenocarcinoma squamous, is it a small cell, a large cell, neuroendocrine, a SMART deficient tumor, is it an adenoid cystic carcinoma from the bronchial tract, because all these tumors require different treatments. But we do have, even in our network, a few % of patients that have the diagnosis, but not enough material for molecular testing. And then liquid testing, circulating tumor DNA is a good choice. On the other hand, the DNA that is extracted from blood allows faster analysis, and it allows also analysis in the cases of relapses, emerging resistance, when you want to avoid repetitive biopsies from the patient. And so I suggest to go actually in the tissue-based pathway in two settings. One is a setting for a lab without access to NGS. And remember, tissue typically is very precious. So you have to save as much as possible. And we typically do need 4 histology stains, HE, PAS, and Elastica Fungison, and also a last H&E stain to check the quality. We need at most 5 immunohistochemistry. And please remember, cytokeratin stainings have no role to play in lung cancer diagnostic. There's good evidence from the ELCC. And in the lung adenocarcinomas, TDF1, ALK-ROS, BRAF is being tested. PD-L1 is again in a squamous, P40, MET, PD-L1. And then in the neuroendocrine and small cells, it's CD56 is tested together with Ki67. So there is a very limited number of immunos. We cut it first line to avoid repetitive cutting. And then the material is being sent to a lab that does the molecular testing. In labs which has access to comprehensive testing with NGS in-house, that can be done in one go. So there is you need your histology slides, the immunoslides, and the 2 molecular slides. And then there's a fast track delivery for EGFR, KRAS. We also do FISH-RAT. and then an NGS testing that is finished within 10 working days. So there are only these two settings, and the pathologist plans the entire processing of the material for histology, immunohistochemistry, fast track, and molecular testing. Now, when you do deep molecular testing, you run into a lot of problems. And the most frequent problem is when you sequence a lot, you frequently have mutations which are difficult to interpret. Even with the good old EGFR, we see practically every day difficult mutations, like rare exon 18 mutations, some exon 20 mutations. And it's difficult to advise the oncologist, what is that patient eligible for TKI treatment or not. And with the network, we have rebuilt all these mutations and tested them in cell culture. And as you can see, the mutations that were classified as no driver don't benefit from TKI treatments. And the mutations that were classified as drivers by our in vitro assays gave benefit to the patients and a prolonged overall survival over chemo or chemoimmune therapies. And that has been published a week ago in Annals Oncology. It's the world's largest composition with a classification of the so-called difficult and rare mutations. Also, one gene, and that is also became clear from the example of MET, can be altered by multi-modes. The MET receptor can be activated by a small deletion that eliminates or skips exon 14. That exon is necessary for degradation of MET, so it enhances the number and the time where the MET receptor is exposed on the cell surface, so it leads to stronger MET signaling. There are high-level amplifications, and there are gene fusion structural alterations that are all druggable in principle, and therefore a single gene can mean a very complex mode of analysis that captures different types of activation. And the third problem is, especially now in the new days with the massive amount of COVID infections we have seen, we see a lot of lung lesions that are even difficult to interpret. And if we had met physically in Prague, I would have given you the chance to give a poll on this biopsy. It's taken from a post-COVID patient, and they are screened radiologically screened in Germany, and then you find lesions which are difficult to interpret. My question is here, what do you think? Is it a post-COVID pneumonia with dense changes of alveolar spaces, or is it a high-grade, low-grade lipidic adenocarcinoma? And what we did to answer that question is we used the comprehensive NGS sequencing, and what we found is a lipidic type adenocarcinoma with a classical exon 19 indel mutation, and that patient received osimertinib, in this case as a TKI for the first-line treatment. So that can help. And the fourth problem we see with comprehensive molecular typing is that we see heterogeneity. And we first saw this in patients that had ALK fusions. And all of these are ALK fusion patients that have a p53 mutation and co-occurring mutations. And when they are absent, they have a much better outcome compared to the cohort that had genomic instability and co-occurring mutations. And that has also been shown by a recent publication where we used single cell profiling. Don't forget, we have stage 4 patients that have a large tumor load and show strong heterogeneity. And if you just look in the orange cells, these are the cancer cells. And these are the cells that have the most heterogeneous phenotype in these stage 4 patients. Can even be that you have a classical KRAS oncogenic mutations, and the cells are not even dependent on KRAS signaling because they have these very, very complex co-mutational patterns. So what it calls for, the complex interpretation of complex genomic data, is molecular experienced high-end molecular pathology centers. And therefore, we have built up the German network with 23 test centers that perform diagnostics and therapeutic recommendations in a standardized way with the same panels, with the same gene panels, with the same recommendations, and they perform their diagnostics with collaborating hospitals and oncology partners all over Germany. And this network, Genomic Medicine, has built national task forces. Task Force Molecular Testing, Molecular Pathology is constantly adapting the complex genomic testing, the gene panels. If there are new drugs, new treatment modes, new discoveries, we have a task force that tries to allocate patients to clinical trials, to collect also data from these patients. We have a task force that collects all the clinical data, the treatment outcome of these patients. And a very important task force is the Muripedia task force in Dresden that tries to interpret all constellations of single or complex genomic findings and connect it to a therapeutic recommendation. And I showed you the result of that task force with the Annals of Oncology paper for the rare EGFR mutation just recently published. And that is a typical cut from a patient report we give. This is a patient with a gene fusion in EML-ALK fusion. So here this cartoon shows only the results from the fusion testing, the RNA sequencing. It says results. It gives the content of the tumor, because that's also very important to give you a feeling of the validity of the data, the number of genes that have been tested for fusions, then the finding of an EML4 ALK fusion with the specific subtype, the nomenclature that has been used to call this fusion, and also the percentage of fusion reads that we see. And you see from all fusion reads, 60% are these ALK fusions. So it's a very solid data interpretation here. And then we give a diagnostic and treatment recommendation. And the specificity of this case was that it's a squamous cell carcinoma with a classical variant 3 ALK, EML4 ALK fusion, and that patient received treatment with alectinib. And finally, also the immunohistochemical markers that we detect are biomarkers and need to be standardized in a very careful way. And in Germany, we have from very early on founded a working group that standardizes PD-L1 testing and gave recommendation. And we have now 120 path labs in Germany that are certified for performing PD-L1 testing. And that is also true for the other markers like ALK or ROS IHC testing. So to summarize that, decisions on biomarkers need to be implemented early on in histopathologic diagnosis. That is very important. We have a massively, rapidly growing disease, so the most effective therapy should be placed in first line. And therefore, we need testing early on, right after the histopathological recognition that a patient has a non-small cell lung cancer. Also, careful tissue handling is utmost in the hand of a pathologist, and he knows all the therapeutic options and plans the entire test strategy from histology to immunohistochemistry to molecular testing. And don't forget, cytologies, when they are optimally preserved by the pathologist, are a super precious material and allow molecular biomarker testings. On the other hand, single immunohistochemical assays, single gene tests are an absolute no-go and a waste of material and endanger proper treatment and endanger patients' lives. Also, intensive external quality assessment is mandatory also for immunohistochemicals, but also at the same time even more for molecular testing and for interpretation of the results. And therefore, an annual, very strict EQA scheme is mandatory, and we call for accredited path labs to deliver these complex genomic diagnostics. I would like the German Cancer Aid that supports with its largest grant in history, the NGN group, and has massively widened the field for targeted treatment precision medicine in lung cancer in Germany, the EU, the Ministry for Research in our state, and especially our patients, which massively support us. And with this, I would like to hand over to Noemi Reguart. She will go more in depth on the emerging landscape in biomarkers and molecular biomarkers. Thank you so much.
Dear colleagues, dear friends, it's a pleasure to be here today in this symposium to talk about the very complex and changing field, which is the emerging landscape in biomarkers for advanced or for lung cancer. Here are my disclosures. So it is clear that the discovery of new targetable molecular alterations, as well as the novel therapeutic therapies such as immunotherapy, has changed the field and the treatment of patients with advanced disease. And this is why we need to identify biomarkers, because we need to give a more tailored lung cancer care. And right now, molecular guidelines, this is why they recommend molecular testing for biomarkers in the initial workup of the advanced disease, lung cancer disease. And as the incidence of the different biomarkers differ across countries, there might be some difference in the preferences for these guidelines with regard to recommendations for testings. However, the majority of guidelines have consensus to test for EGFR, ALK, ROS, and PD-L1 gene testing, and most guidelines also recommend BRAF and NTRK. However, as you can see here in the lower obvious slide, there is plenty of novel emerging biomarkers that are currently only recommended by few guidelines. And one of these emerging biomarkers, it's KRAS. This is a clear example of why it is very important to identify the broadest number of patients with genetic alterations, because KRAS was considered historically as an undruggable disease. And indeed, is the most frequent oncogenic alteration in lung cancer, closely related to tobacco smoking. So this oncogene most recently has other options for treatment, as its inhibition has been proven to be effective by using small inhibitors that bind to the inactive protein. But as you can see here, this is only happened for a subgroup of patients with a specific variant of KRAS mutant, which is G12C, whereas almost half of the patients still are in need of, half of the patients with KRAS alterations are still in need of targeted therapies. And KRAS has also been used as a way of identify or to exclude other oncogenic alteration, as well as a negative prognostic biomarker for response and outcomes. And this is a really busy slide, but just to show that the number of oncogenic oncogenic alterations with potential target for target inhibitors is growing exponentially. As you can see here, several of them are being studied for the use of specific targeted inhibitors, and indeed, in a lot of them, such as RET or MET exon 14 skipping mutations. So we already have specific and approved targeted therapies. And this is why, as commented before by our colleagues, it's very important the use of expanded NGS panels in the clinical setting. But beyond the oncogene-based molecular classification, the importance of co-occurring alterations has recently also attracted interest. And this is because these co-occurring mutations are determine the molecular and clinical heterogeneity of the most common oncogene-driven lung cancer. But when we are considering these occurring mutations, we have to keep in mind several factors: the intra and inter-driver mutation, also the clinical context, that is the stage of the disease, and also if the patient or the tumor has been exposed to the treatment. Also very important, we will comment on that, the clonal nature of the mutation, and also the impact that the immune selection and mutational process can have on the these co-occurring mutations processes. And here you have, we thought that co-occurring genomic alterations were rare, and as you can see here in this nice representation with different, one of the major oncogenic mutations such as EGFR, KRAS, and MET, as you can see, co-occurring mutations are very common. There are some of these co-occurring mutations that can happen in all three different genes, such as TP53 mutations, and others are specific for certain oncogenic alterations, such as KRAS with STK11 or KEAP1. But very importantly, to see how just in the middle, we can see that these major oncogenic alterations can indeed coexist without they were exclusive, and we can see they are not longer seen as exclusive entities. And the clinical impact of the therapeutic, the clinical impact of these different co-occurring mutations remains largely unknown, but with broader use of NGS techniques, now we have better idea of the impact, for example, in this case, of TP53 can have on the different subset of major oncogenic alterations. So molecular stratification of major oncogene, but also taking into account these co-occurring mutations is very important to optimize in future strategic therapeutics. And this is important also for KRAS. KRAS is one of the most heterogeneous diseases. It cannot be considered as a unique disease, and it can have an additional mutation in half of the KRAS mutation. And as it happened with TP53 commutations such as STK11, as you can see here in this Kaplan-Meier curve, concurrent commutations with STK11 and KRAS can modify the outcome of patients with advanced disease. We commented it before. These major oncogenic alterations cannot be seen anymore as independent entities, because as you see here in this nice work by Dr. Passaro recently published, you can see that there are some oncogenic alterations such as KRAS, EGFR, and MET amplifications that can coexist with other major oncogenic alterations, and among them, MET amplifications, it seems to be the oncogenic alterations that can higher coexist with other oncogenic mutations. And these co-occurring mutations can also have importance in the resistance, primary resistance of the therapy. And this is a field that has not been widely explored, but for example, we have quite data about patients with EGFR mutations in which, for example, we know that TP53 mutations can define the sensitivity and outcomes with specific EGFR tyrosine kinase inhibitors. And for MET inhibitors, that we have a more complex scenario. We still have not elucidated which is the role of all these different mutations, but for example, we have some mutations in the MET tyrosine kinase and might have importance in this highly heterogeneous disease. And this is why the clonal dominance is very important. This is a nice concept that has recently been described, and it's reflecting the incidence of the clonality of these different mutations that we can have within the same tumor. And it's very important because by knowing which is the clonal dominance, we can know whether this tumor or this alteration is acting as a primary oncogenic alteration or it's acting as a subclone resistant alteration. And here you have a nice example for MET exon 14 skipping mutation, in which it's, as we mentioned before, is a high heterogeneous disease. The majority of MET exon 14 mutations are seen as subclonal events. However, in some driver genes, as you can see here for HER2 mutations, it can also have a subclonal performance, whether with other mutations such as KRAS, it can have the same clonal dominances. So very important, very nice field, a lot to do, whether this information of the clonal C can give us more chances to better select the therapeutic strategies for these patients with concurrent mutations. Currently, we do know that all patients with oncogenic drivers that are treated with specific targeted therapies, they ultimately develop mechanisms of resistance. And we do have more evidence about how these mechanisms of resistance overcome, and there are different types of them. Some of them on target resistance, others are off target, and means they use bypass pathway activations. Others lineage transformations, such as histology transformation to small cell lung cancer or transitional epithelial to mesenchymal transition processes. And some genes normally develop on target resistance, and this is the case of EGFR mutant patients or ALK rearranging patients. But very important, this field is changing very rapidly, because with the arrival of new more potent third generation tyrosine kinase inhibitors, the landscape of these on target and off target resistant mechanisms is changing absolutely. And this is what has happened with the use of osimertinib, with the use of osimertinib in patients with EGFR mutations. And MET, it's very important because it's one, if not the most important, of target mechanism of resistance seen in a lot of oncogenic drivers. And this is why this MET amplification bypass is one of the strategies that is being widely explored in clinical trials ongoing right now, with the combination of tyrosine kinase inhibitors blocking the primary oncogenic alteration, as well as the MET amplification as the mechanism of resistance. And we have other evidence that also there are other oncogenes, such as STKA, that can modify the microenvironment, creating a more non-immune inflamed microenvironment, and therefore could be also a predictive, negative predictive of response to immunotherapy. So to end my presentation with just some comments on the future perspective in non-small cell lung cancer therapy. And for sure, as commented before, liquid biopsies is one of the fields and techniques that is it's having now more attention, because it has plenty of applications, not only in the metastatic setting where we are used to, but as we will see now, it can have also applications in the early detection and, for example, to detect the minimal residual disease. We are more used to see this slide, and I am not going to tell you what are the benefits of doing liquid biopsies for patients, but because we all know that liquid biopsy are non-invasive techniques that allow monitoring and can overpass these patients without enough tissue sample to perform all the genetic testing. But liquid biopsies are getting more relevance in other setting of the disease, not in the advanced setting, but in the early setting. And this is very important because we know that patients that are operated on have high risk of, even if they are operated on, they have high risk of relapse, and even treatment with chemotherapy only decrease the risk in a small subset of patients with early stage non-small cell lung cancer. And the same happens with the new studies and the new evidence we have now with phase 3 trials with immunotherapy. So detection of the minimal residual disease, that is the small amount of tumor cells that are in the bloodstream after the radical therapy, can help us to identify those patients that most benefit from adjuvant therapies. And that has been demonstrated, as you can see here in this nice work from Lunga, with the detection of minimal residual disease in patients after surgery, how it can identify the minimal residual disease, can identify the patients with higher risk of relapse, and therefore those patients that can most benefit from specific adjuvant therapies. And this importance of liquid biopsies, not only in the early setting, in advanced setting, but right now we have more evidence that it can also be important to advance the progression, advance the identification of the progression in the CTs, or also when we are treating patients with maintenance treated with immunotherapy, to identify those patients that are going to have longer responses, or those patients who are going to be resistant. So these are my final take-home messages. Identification of biomarkers is key to a more tailored approach to the management of patients with non-small cell lung cancer. There are existing and emerging biomarkers, all them implicated in sensitivities to targeted therapies, resistant mechanisms, and also as prognostic and predictive values. And concurrent mutations are no longer seen as infrequent and can indeed affect response to therapy. And for sure, the future of testing by using liquid biopsies will be a really valuable tool to assess the tumor stage at all stages of the diagnostic and therapeutic journey. And with that, I finish my presentation, and I like to move into the panel discussion. So Solange, thank you so much for your attention.
Thanks a lot, Noemi. It was absolutely amazing to see all this data from Reinhard and yourself, showing the complexity, but also all the perspectives in terms of treatment and management improvement for the future. I will just introduce the panel discussion, raising some points about the how to do, how to apply, and trying to launch, I hope, a debate and a discussion about our ways to treat patients across countries in Europe and maybe beyond. So this is my discussion slide. First of all, I'd like to remind all of us about this publication, which is already an old one, but was a revolution at the time. It's a publication for Vogelstein, when he was describing for the first time a kind of a, I would say, a little pessimistic, but a general point of view and summary of what we call the selective growth advantage, the driving capacity of some alterations in cancer. He was concluded there that the low-hanging fruit had been caught already, because more and more, after having discovered some drivers, we are rediscovering the same drivers in different disease types. And he could classify these drivers. He was finding around 80 in this trial, drivers as well as suppressor genes, suppressor oncogenes. He could classify them into what he called 12 major pathways. You can see here the NOTCH, the MAP kinase, the STAT, the PI3. And I guess today we still agree with Vogelstein, even if it's almost 10 years later, that we might not discover so many new targets, and they still can be classified or correspond to this basic classification of what we can call tumor biology. But of course, in lung cancer, we defined it by each target being a specific entity. And as it was described before, all these pies divided into very, very small slices, which represent a specific disease entity with its own dedicated and tailored compounds to be used, actionable in adenocarcinoma, theoretically actionable in squamous cell carcinoma, but today not applicable, unfortunately. But basically, in the non-squamous part, a lot of options. We have been working on this, and this can be told about the squamous and non-small cell lung cancer, but about many oncogenes across other diseases. We can classify them according to their actionability. So a target can be well known to be a driver, but not actionable. Driver doesn't mean actionable. That's why we developed this SCAD, the actionability scale, within the ESMO Precision Oncology Working Group, which was published already and is applied in ESMO guidelines now. It is a framework to rank genomic alteration as potential targets for precision medicine. And the ranking is based on actionability. So, of course, EGFR is one, ready to use, improved outcome in clinical trials if you action that. But, of course, we can go down up to 5 or even the lack of evidence. And you can see that in the tier 2, the SCAT level 2, you can see an anti-tumor activity when you action the driver, but we don't know the magnitude of benefit. And going down the scale, you go to only preclinical evidence of actionability to the lack of evidence of actionability. And in everything we do, I think as physicians, we need to keep in mind where we are in this pyramid, because while we are very, very confident when it's 1, we should always be very critical when it's 3, 4, or even 5. Even if we are convinced, our conviction is not enough. So that's quite important. I just want to show you a case to speak about molecular alterations, and I will end up with this consideration about 4 or 5 SCAT scale. So this is a patient of 1957, a lady with in general good health, no comorbidity or symptoms before. She was a previous smoker, had stopped some years ago, 30 pack years, and the initial presentation of her disease was an epileptic seizure in the blue sky, as we can say, a focal seizure affecting the right arm. She performed a lot of tests, you can imagine, and was diagnosed by transthoracic biopsy. This is about her. She was diagnosed with pulmonary adenocarcinoma of the right upper lobe. I can let you watch the picture. Classified T3 because of 2 nodules, N3 because of supraclavicular lymph nodes, M1C because of brain, as you can see, a dramatic brain infiltration, as well as bone metastasis, as you can see in the pelvic bone, in the ischiatic spine. You can also see the molecular characterization, which was initially performed with an ALK negativity, the absence of BRAF, HER2, KRAS mutations, but a P53 mutation and a negative PDL1. Of course, we all have our ways to look at data. We like to have molecular tumor board or tumor boards because they are needed for constituency, the population we treat, and also the institution to be reliable. Of course, it's also very often driven by teams who have interest in research. So it might not be the case everywhere, but this molecular data have to be combined with the knowledge of specialists to be able to drive to the right treatment decision. We all had year after year our local guidelines. It was the one from Dr. Malowski in Canada already 2 years ago, where she had this ranking of alteration and this very nice question of who to test, what sample to test, how to test, when to test. So all these fields are moving quite fast, just to tell you that we could reduce this slide every 6 months, more or less. So just to think about the future of molecular biomarkers, and Reinhard told us to it before, this interprofessional decision is really based on lots of potential data to accumulate genomic data, but of course also maybe circulating cell-free DNA, a lot of immunohistochemistry already, but who knows, maybe proteomics and metabolomics to come. But I wanted to stress here that there's nothing you can do in a decision-making process without clinical or pathological data to be strongly looked at and significantly analyzed. And that's what I will come to later on. So let's go back to my patient. So she had a care in a private practice. They had no formal tumor board because they were looking at all tumor types. So they had no tumor boards for specific lung cancer. They were happy with their panel and they decided to go for pemetrexed, pembrolizumab, and platinum with 2 cycles leading to stable disease. The patient was describing very severe fatigue after this 2 cycle of platinum-based pembrolizumab, weight loss, and then she asked to come to the university hospital. We were not very satisfied with the panel, which was missing many biomarkers that today we would like to do or perform or look for, and we find this MET exon 14 skipping mutation. It's very classical that we only find them when you use the comprehensive panel and the fusion panel. Very classical I would say, mistake. And we moved with this patient with a stable disease and a lot of brain mets to the capmatinib treatments, which led to an excellent partial response, almost complete, as you can see, ongoing as per just before this meeting. So that's about quality of care and optimal cancer care. Of course, now all the guidelines, and it's also a moving field, define what you are supposed to test. And you can see that here, MET exon 14 is called essential to NCCN, but also essential as part of a multiplex panel for the ESMO, ASCO, and Pan-Asian guidelines. So I think that's something we need to follow. Of course, and Anne-Marie can speak about it, this is the ideal world. And we are not living in the ideal world. And that's what Luce has produced. We evoked it before, looking at what panel, where the NGS, what molecular alteration can be looked for across countries in Europe. And you can see that there are data a bit controversial about accessibility, meaning probably not homogeneous, but many of these obvious mandatory targets are not to be reimbursed in many European countries. So really something which is an unequal treatment to patients. Let me go back to the SCAT 3, 4, 5 scale. So we have to take in mind or keep in mind that what we call molecular tumor boards usually qualify the search for biomarkers which are outside of the standards of care. Because if you have an ALK or an EGFR, you don't need a molecular tumor board. You need a multidisciplinary tumor board. You need the diagnosis, the clinical and pathological data that you have with your surgeon, with your radiologist in the multidisciplinary tumor board. So molecular tumor boards are usually screening for unknown mutation, SCAT scale 3, 4, 5, or X. And this is a nice publication from the group of Jean-Yves Blais, who was looking at this patient beyond the usual standards and all the care, which is, I would say, evidence-based, and looking at this patient where 6% of the patients were actually receiving a matched therapy based on the unknowns of new targets, with an overall response rate of 0.9%. The conclusion of these colleagues about the pure molecular tumor board beyond standards is that molecular screening should not be used at present to guide decision-making in routine clinical practice outside of clinical trials. And that's a debate in our field. Are you allowed to treat a patient because of an assumption? And that's really something we have to keep in mind every time we discuss with the patient for an informed consent. And with this, I think it's quite important to keep in mind what is standard. It was discussed before, but I like these slides that we just updated, which is about everything which came new in 2022. You can look at the slides quietly afterwards. They are listed with the A to the G letter, lorlatinib, entrectinib, selpercatinib, capmatinib, amivantamab, trastuzumab, sotorasib. All were FDA or EMA approved in 2022 timeframe. So can you see how much this scheme of standards of care SCAT1 can be now used in the daily practice? And this is multidisciplinary tumor boards. So let's keep it in mind. And with this, I guess we can now open the debate and try to discuss together how we perform it at best in our clinics. I will maybe just go back to my colleagues. So basically, maybe I will ask to Noemi, who lives in a different environment as compared to mine or the one of Reinhard. I think every country has its own way to move. How do you perform, or where do you discuss your molecular data? And who is your counterpart? Who is telling to you, oh, he should have radiation or he should have an adjuvant treatment or not? How are you discussing that in lung cancer, of course?
Yeah, thank you, Solange. So, well, I guess in our hospital right now, it's we do not have the optimal situation to discuss these patients, but we are trying to find a way to discuss these patients. So I could say these molecular results that are not the classical EGFR or ALK, isn't it? Because those are straight away decisions. So there are other cases, we know in clinical practice, we sometimes find cases in which we have two different molecular alterations or in which the molecular results are not clear for us. And these cases right now, we are discussing them directly with the biologists. However, I do think that the multidisciplinary molecular tumor boards are very important because it's not only the biologists, it's the oncologists, it's the pathologists, it's the pharmacists, isn't it? The ones that have to be there, because if you identify a rare mutation, you also have to find the better option for these patients in the setting of a clinical trial or an expanded access program. So in our center right now, we are trying to organize these multidisciplinary meetings because it's very difficult in our case to put these discussions into the regular tumor board, lung tumor board, because that could be long time. And I think these discussions need its time. It's proper time to discuss in a proper meeting. This is how we do have it right now in our center.
It might become even more important when we start to look at early disease, right? You know, the adjuvant EGFR TKIs or the neoadjuvant IO, where you will probably want to have this biomarker being discussed in presence of the surgeon, for example. So that's probably where we have a kind of a door to pass, is to be able to have this discussion with EGFR and PD-L1 when the surgeon is in the room, because otherwise it's not going to be explained well to the patient or even done in the future.
This is going to be, Solange, a great challenge because with all the introduction of the immunotherapy in the preoperative setting, we will need to have this information, isn't it? In the preoperative immunotherapy, you need to exclude EGFR and all patients, and that means that you have to run tests for this testing before taking a decision. So this is going to change a lot the dynamics of the multidisciplinary board, lung board. So, but it's something that we have to do because everything is changing very fast, and we will have to adapt to the new results and new data.
Reinhard, you are sitting in all these tumor boards, probably the molecular one as well as a multidisciplinary one if you have two different ones. How do you perceive the efficacy and the functionality of such tumor boards?
Actually, you're right. Tumor boards are now taking quite a significant share of our time. And the pathologist is present in all these boards, not only lung, it's breast, whatever. In specifically in lung, I would like to stress that in our center we have two layers of multidisciplinary tumor boards. One is the primary decision board, where you have a newly diagnosed patients, and of course molecular diagnostics is important, but it's not everything. You need to assess the stage of the disease. Is the diagnostics complete? Is a PET missing? Is the patient undergoing resection? Is a systemic stage of disease? Is the CNS data available, and so forth? And that is discussed in our, let's say, organ-specific lung cancer board. And at that point, you typically already have a few biomarkers. You have everything that's available through immunohistochemistry. So you would have a PD-L1 status by the time. You would have probably most cases the rapid diagnostic. You would even have an EGFR status of that in that instance. However, the full molecular diagnostics takes longer. And so we go in a molecular tumor board with this data for the patients that need systemic therapies, where all these wonderful markers that Noemi showed are important to select targeted therapies, immune therapies, maybe in the near future also combined personalized immune therapies and so forth. And that requires a multidisciplinary tumor boards that has access and availability of the full molecular data. So we have a two-step board decision for the primary decision, resection, surgical therapy, systemic therapy, completeness of diagnostics, and the other is a molecular-based board. Yeah.
Yeah, I was discussing today with one or two pharmas about the trials of tomorrow. And what we can see is more and more these biomarkers will be integrated into the care of curable radical treatments, surgical or radiochemo of these patients. So do you agree that there is a difficulty to reconcile the division into two parts, when suddenly it's going to be maybe a neoadjuvant EGFR treatment or, already planned consolidation treatment or so on? Because then you might want to have everybody in the same room, right, to make sure that we have the same language. Would it be possible, do you think, that the tumor board of tomorrow, longer, broader, but everything in there?
Yeah, but if you have the neoadjuvant therapies coming in, you will have the need for a two-step procedure. You will have a board that makes the first decision and say this patient is non-surgically resectable, for example, or it's a stage 3 disease that is could be a candidate for an neoadjuvant immune therapy. So you make that decision in your first board, and we have to define carefully what biomarkers are needed for these decisions. Because you don't want to treat, let's say, an EGFR mutated lung cancer with a neoadjuvant immune regimen.
No.
So you need also to have some molecular markers for these decisions. And then, of course, a lot of these patients after the immune therapies undergo resections. And then you have to reassess all the data again. We have seen wonderful remissions in the some of the clinical trials we participated in with neoadjuvant immune therapies. There are patients that have 100% response, complete pathological response, and that also needs to be assessed, and then a plan needs to be elaborated in a second board after this.
Anne-Marie, I wanted to ask it, but it's even written in the chat with the question. The question from one of our auditor is to ask you, with a lot of old and new target becoming druggable more and more, even KRAS, what do you think should be done or prioritized to increase and accelerate patients' access to this new treatment? So, of course, what can we really try to act on in the next months or year in order to make the whole strategy being better, more equal in Europe? Is it testing? Is it, I would say, reimbursement? What are the main pieces or ways to move to make it more balanced?
All of it. I want it all. No, I think, we need to have a common sense joined up approach to this. We need to ensure that there is that consistent access to testing irrespective of where you are, because then you're going to get more accurate data as the percentages of all of these different oncogene-driven mutations and the co-occurring mutations that are happening, and you're seeing more frequency as well. And then as well as that, we need to work with the policymakers, the HTA processes within a country, the payers, the industry partners, to make drugs so that they are, I don't know if the word is easier to reimburse, but in a way that they can be reimbursed so that people can get access to it. So you have that sort of joined up thinking. And I think by generating the data and working with all of the stakeholders in terms of drug access, that's one way we're going to accelerate and increase access to new treatments. But I will say it is very interesting to listen to the biomarker discussion. I feel like I'm in an MDT setting, but I would just like to say, it is very complex. Things are changing all of the time, but just because of that doesn't mean to say we can't try harder and maybe move the more traditional MDT to something that's more appropriate, because an accurate diagnosis should not be seen as a luxury. It should be seen as a normal part and a standard of care for anyone with lung cancer. Because let's be honest, what we're talking about is living with your disease and dying from your disease. And that's the bottom line.
And Solange, can I add one more point? I found it super interesting and also shocking to see your slide where you showed the gaps in reimbursement. In the many markers, we know there are effective therapies that save and prolong lives of patients, and they are not done because they are not reimbursed in many countries. So I think that is a European task. To move
it's a very complex topic, because there's even Natasha Lay told us from Canada, from Toronto. She likes the economics side of oncology, and she made a study in Canada trying to see if at the end testing and prescribing targeted therapy makes lose money to a society because, as you have seen, accessibility is proportional to GDP, more or less? Or does it make win or gain money or spare money? And the end, the conclusion of that is if you have the right drug for the right patient, at the end of the journey of the patient, you have spared money. So that's really something which is very useful, because even if you sit as an economist, right, and trying to make some, I would say, benefit for the society and not for the patients, you should sit on the side of precision oncology. So it's quite interesting to keep it in mind, because more and more we will need to produce this data to convince maybe some other politicians than the one who support the patients, right?
Yeah, but Solange, let me just finish this one thought. Let's say if Europe identifies gaps in infrastructure, let's say there's a motorway is missing or a railway is missing, they put funds to specifically close that gaps and build infrastructure. Now we have exactly in the precision medicine strategy of the EU, we have identified gaps. And I think it's a pan-European task to fill that gaps and accelerate precision medicine, put some funds into that.
Absolutely. It's high-level EU politics. Remember, we have the EMA, which will look at science, but every country has its HTA. We have tried to make an homogeneous HTA, the European HTA, and at the time being, we didn't manage. It was not a success. So that's probably the only way to move. That reimbursement of drug is not a country or a regional decision, even an institutional decision sometimes, but should be a European decision. Just also because you shouldn't be treated differently according to where you live. So that's some things that as physicians we should not accept. Just so I have some molecular questions for you, Professor Büttner, by the way, and I will have my last question will go to Anne-Marie, but maybe also you can jump in, Noemi. What do you do with these strange cases when you find two alterations, two mutations? We have seen some of these cases with mainly at resistance, where you suddenly have an ALK and an EGFR mutation. So should we take into account this dual mutation as being fake results, or do you really think that sometimes a driver might lead to a clone of another driver being present at resistance? Have you seen these cases?
I think if you have this clear truncal oncogenic driver mutations like EGFR mutation, they rarely co-occur with another truncal oncogenic driver. We sometimes rarely see these cases, and then a pathologist should also analyze whether the patient has two cancers, and that occurs also. We see specifically in lung, it's not rare to see that a patient has a multiple tumor that forms a common tumor mass and then is seen clinically as a uniform disease. However, there are some rare cases where you have subclones that are driven by different oncogenic drivers, and then I think you need to carefully discuss this in the board, in the multidisciplinary board, and then try to drug one driver and carefully monitor whether disease responds. Monitor it early and check whether the therapy is effective and really helps the patient. And if not, you have to change it early on.
Noemi, you got these cases where EGFR and ALK, and we tried in the past crizotinib and erlotinib. Do you still try to discuss it with your colleagues? What do you do in this rare situations?
This is a very interesting topic. And you know why? What I do believe that this is one of the reasons why we need to further pursue to do NGS to our patients. Because if we don't have these cases, we are not going to learn about this. And this is something very new, because we thought that KRAS could not coexist with MET exon 14. And now we have cases with KRAS mutation and MET exon 14 or ALK and KRAS. And in reality, we do not know how to treat them. Sometimes we can infer the clonality, what Dr. Reinhard said just now. We can infer it by looking at the allelic fraction of this tumor. And then if you see a higher allelic fraction, you say, okay, it's going to be the dominant clone in there, isn't it? but we do not have trials testing for these specific commutational tumors. So I think, I don't know, there's a lot to learning here, but I am sure, I'm a believer that with the higher numbers we have, we will get more information about how to best treat these patients.
Thanks a lot. My last question will go to Anne-Marie. It's about the SCAT. I guess it has some importance for patients. It's about informed decision, but information is not only about a doctor speaking nicely to the patient, but also about the data supporting any proposal. And I've been seeing quite a lot of patients participating in your groups, right? EGFR, ALK patients. And very often we see here passing by proposals of treatment, repurposing of drugs, or alternative options, which are not really documented. You can imagine all the debate about adding metformin on an EGFR inhibitor and so on and so forth with no data supporting. How can we in the community where we all try to do our best, do it right? Convey the data or the proposals which are not at risk but might be acceptable. How to, because I'm sure you very often as patient advocacy groups, right, have this question of should I take an additional drug? Should I try this way? Should we try?
Yeah, you do get questions whereby, you know, if there are limited options available, well, what's next for me? What could I possibly go out and look at? Because again, it's that life and death situation. But I think what it comes back to is having the discussion in the clinic with the person who's there with you and who's living with this disease, and explaining as clearly as you can, look, there's drug X, Y, Z, here's the information about it, here's the data around it in lay terms, and allow that person to go away, read through the information and come back and really have a discussion with the clinical team as to what their decision wants to be in terms of a different type of drug or repurposing an older drug, because it's by having that information, that awareness, that you can have proper shared decision making and person-centered care. And I think by the clinicians having those conversations, they can then go back to policymakers, decision makers, HTA, whatever it might be, and say, well, this is the real life experience in the clinic and this is what's needed, because real world evidence is again something that's becoming so many buzzwords. So like if you're having this real world evidence in your clinic, then you can go back and use that, because they're going to listen to you probably more readily than they're going to listen to an anecdotal story from a patient organization. So you have a really important role to play.
Thanks a lot. So with these very wise words, like usually, Anne-Marie, we get to the end of this meeting. We're 1 minute late, but I'd like to thank you all, Anne-Marie, Reinhard, Noemi, and all of you listening to us for being part and asking questions. And I look forward for the next meeting to see what we will have been able to change or to improve in the field of precision oncology. And I wish you a nice evening. It's already pretty late, and a nice end of the Congress or follow-up of the Congress in the next days. Have a good evening. Bye-bye.
Thank you.
Thank you.